Okay, everyone, thank you very much. Just quickly, if you can see in the lower left corner, pollev.com. If you can use your phones, if you'd like, I'll be asking a few questions throughout the presentation, so you can refer to that and participate. All right, let's get started. So our one-liner, we have a 54-year-old African-American female with a history of uncontrolled asthma, hyperlipidemia, and anterior uveitis, who was referred to our ED for an abnormal EKG. We come to find out that she had substernal chest pressure, intermittent, non-exertional, for 10 days. Her review system was negative otherwise. Some other history, some family with heart problems, heart issues, and her father at age 70, 2 cousins with lung disease. Those are her medications. You guys can read it. And socially, she drinks alcohol, a few drinks per week, never smoker, denies recreational drug use, and she works an office job. So she shows up. These are her vital signs, grossly normal, a bit tachycardic, borderline, but otherwise within normal range. BMI 34.4, no obvious JVD, regular rhythm, normal S1, S2, no deficits, and mild pitting edema up to the shins, but this is chronic per the patient. And this is her initial EKG. So I'd ask maybe the audience or one of the panelists to maybe participate and give their best shot.
Dr. Stern, if you have any thoughts on this.
Not sure you're asking me, but okay. Signs for the PVCs, right frontal branch.
Excellent.
A little non-specific. I'm going to pass this
I'd
mic
like
to
to
the
left
panelists.
take
If you could pass it back and forth when you want to speak.
We'll continue. And her chest x-ray. Does anyone want to take a shot at this?
So I would say that,
Sorry, it's a bit small on that screen, maybe larger here.
so it's a reasonable inspiratory effort. I think the right hemidiaphragm is probably elevated a bit. The heart may be enlarged. And I think there's probably some cephalization of the vessels. I don't appreciate any thing in particular at the hilum. Maybe there's something next to the aorta, but I'm not sure in terms of adenopathy. And on the lateral, you can just see a little bit of infiltration posteriorly at the base. It's sort of that, we call that a spine sign. And there's a lack of oligemia at the base there. So maybe there's some infiltration there, edema, something like that. Otherwise, I think it's pretty unremarkable.
Excellent, thank you. Okay, some admission labs. Cardiac labs, we had a high sensitivity troponin of 18, trended down to 17, with a B Nancy P 976.7 and a D dimer of 0.82. The ED department team obtained the CTA PE, imaging was negative. Otherwise, the lab work there is, again, normal. Some additional labs, the team felt it was necessary to potentially work up some other etiologies for her presentation, CRP, 17.7. Otherwise, the other results are negative or normal. Okay, so open this up. And if you can,
If all the fellows log in, that'd be great.
I'll give you a minute to participate. Is it showing up?
It's pretty straightforward here. Everyone wants an echo. The panelists think that's the right next step. Anything else you would do? Okay.
Right.
All right.
Okay, and so we have our echo here. Okay.
And Vikram, take a look at Dr. Agarwal.
So you can see that the left ventricle looks a little bit more on the generous side, the size-wise. There are some regional wall motion abnormalities. The lateral wall does not seem to be squeezing as hard as you'd want. It is slightly hypokinetic. Similarly, towards the septum also, there may be some hypokinesis. The wall motion is not really that well appreciated. There is some dropout in the anterior wall. As you can see, there is some thickening of the valves otherwise.
Okay. Okay, code here. We put a Doppler over the valves.
So this is obviously a four-chamber view. There is some mild TR, trace TR that you can see. Again, you have the thickening of the valves, mitral valve thickening. You can see you are having a lot of activity during the images acquisition. So the wall motion is tough to assess on that. And obviously this patient will benefit from some contrast for better endocardial delineation for wall motion assessment. Right ventricular function looks kind of okay, but it's tough. Again, probably the TAPC is okay.
And then again.
So this is a better signal. We saw that on the parasternal short axis view also, but it was a single view that you have this thickening of the mitral valve. There is a bit of a tenting of the mitral valve that you can see. And then you have this eccentric, probably moderate mitral regurgitation that is there hugging the lateral or the posterior wall.
Here we have our Definity images with Definity.
So over here, pretty much what we suspected on the non-contrast images, the lateral is global hypokinesis first to begin with. The whole ventricle is not moving as well as it should be robustly. The inferior and the lateral walls seem to be the worst over here. There is not much thickening at all that's happening, if anything. But again, overall, globally, the heart is down with some regionality in the motion. Probably 15, 20, 25%, 15 to 20%, I would say, looking at this.
Let me deactivate this. And if you can participate, what would be your next step after this echo?
Let me ask while we're doing this to the panelists, what's your differential so far based on this echo?
I think you definitely need to exclude coronary artery disease. So I think doing a cardiac cath or a CTA would be probably one of the next steps, and then clearly MRI. I don't recall the patient having any evidence of troponitis. Was there troponitis at the beginning? 17, which would go with more of a myocarditis picture. The CRP was elevated, so it's something to think about. But there wasn't anything like so profound in the history to suggest myocarditis. So probably cardiac cath or CT would be my next immediate thing. I'm not sure if you and then obviously cardiac, but as a follow-ups then.
So I guess based on the regionality, you have to rule out coronary artery disease. Obviously, that's the most common cause. And whenever you're thinking about these patients, again, the patient is relatively young, so coronary CTA would be fine. The benefit for a cardiac cath obviously would be the fact that you can get better hemodynamics based on heart failure assessment if you need pressure assessment, how the heart failure status is. But CT is pretty reasonable in this sort of a situation, especially since it's a relatively low risk patient with not much troponin elevation.
Okay, thank you both. So we went with the CCTA. So tried my best to capture these vessels, but again, the next slide will provide a better image of all vessels kind of lined up next to each other.
Can you tell what you see, bro?
Yeah, sure. So as we're kind of coming on this, I guess you would say axial view, right now we have a good view of the RCA coming posteriorly and coming into the RPDA. We can start over. Again, you want to look at all structures, anatomy, make sure that you can count the number of pulmonary veins. Look at the overall size, look at some of the valves when you can, and then here, let me just pause this. Here, it's kind of hard to go back, but you can see the left main appropriately coming off that side, breaking into, again, the left circ, LAD. You see your first diagonal coming down. You see the left circ, still pretty moderate size vessel. And again, you can see here another diagonal coming off, but no obvious obstruction or stenosis. All right, so then we'll go to the next slide. Here, and using this feature on vitrea, we're able to kind of line up the vessels here to see it more clearly, even though there is some motion, maybe ectopy for this patient that blurred some of the images. But Dr. Agrawal, I see that you'd like to.
No, I think I was just going to say that this is not the greatest quality of cardiac CT that you are going to find, but it is of diagnostic quality, at least in this particular situation, right? It rules out any major coronary artery disease. Can we rule out some mild lumpy bumpiness on this or mild luminal irregularities? Probably not, because the patient probably had arrhythmias during the acquisition. As you could see on the study, the patient did not take a deep breath. So given the fact that the patient has a 15 to 20% or 20% ejection fraction, you do not see any major coronary artery disease. So the ejection fraction and the wall function is not suggestive that, or the CT does not suggest that the low EF in the presentation is consistent with coronary artery disease in this situation.
Okay.
I guess the other thing that is apparent from the CT is that there is no obvious lymphadenopathy in just CT as well. So keep in mind.
Correct. We can speak about that more later. And, okay, let me notice a trend with the questions, not very different, but, you know, next step.
You can read those apologies for.
Sure.
We've got folks coming in from every side, which is
You got it.
great,
So-
great today, so just so they can know what the answers are.
Sure. Cardiac MRI, cardiac PET CT, start GDMT, consult heart failure, and or something else.
Oh my
My
God.
lower
Look at that heart failure.
You left the
I know.
Okay, so across the board, cardiac MRIs, use the lowercase m.
This is like the board exams where like a patient comes with a chest pain, do you give oxygen first or do an EKG first? I guess you do both at the same time, no?
Yeah.
No, and I guess the other thing is that would have anybody done something differently if on the CT there was lymphadenopathy? Would that have made change? In this case, is obviously, I think everybody would agree it's a cardiac MRI because there is nothing to speak of sarcoidosis, which if it is the diagnosis. But I would say if there was lymphadenopathy, I'm not sure I would have gone to a cardiac MRI right away. Maybe I would have considered a PET. And
Okay. Well, we went with the cardiac MRI. Let's see if I can expand this. Okay, and if Dr. Agrawal, you could take us through, or Dr. Trevier.
Oh my God. So again, this is the short axis images of the left ventricle and the right ventricle. This is what we call our short axis in a stack going from the top of the left ventricle. At the top left-hand side, you see the mitral line and the tricuspid valve, and then towards the bottom right-hand side, you see the apical images. And the goal of this is to look at obviously regional wall motion, ventricular size and function, regionality of wall motion, etc. Pericardial effusion, any extracardiac stuff that we can see. So over here, we see it's a dilated left ventricle, obviously, which we had seen on the echocardiogram. The ejection fraction pretty much is confirmed what we saw on echocardiogram. Over here, you can start appreciating a little bit more of the features as far as the wall thickness and everything is concerned, slightly better probably than what you saw on an echocardiogram. You can see the lateral wall, especially towards the mid, is thinned out. There are prominent trabeculations that are present again in the mid to apical segments. So it is consistent so far with the dilated cardiomyopathy, regional wall motion, severely reduced LVEF, and there is obviously this thinning of the lateral wall that you're seeing. There is some mild MR and mild TR that you can see at the top. Obviously, this is not the best way to quantify it.
The coronary, beautiful. The coronary. Show it.
Yeah, yeah.
Okay, let me play this slide as well.
So now this is something that all us cardiologists are more familiar with, right? You have your 4-chamber, 2-chamber, and 3-chamber views. Again, the orientation is a little bit different than what we are used to on echocardiogram, but you are seeing the same findings, what you saw on the short axis. This is a confirmation of that. is that you have global hypokinesis, dilated left ventricle, and there is regionality that is especially prominent in the inferior and the lateral walls. Like seems to be like bites taken out of an apple, at least in the mid-lateral wall and the mid-inferior wall, where everything else is like significantly hypokinetic. It's almost like a hinge point that's present over there, and that was the same region where you're seeing the thinning of the wall as well.
And then we can speak about LGE. I know
So-
it's kind of small here. I wish I could increase the size for you.
So after the cine images, obviously this is the reason why most of the cardiac MRIs are performed. You are trying to do tissue characterization, and the bread and butter of tissue characterization is late gadolinium enhancement. Essentially, you inject the gadolinium and you wait about 7 to 10 minutes before you get these images. That is why it is called as late gadolinium enhancement. For people who are not familiar, there is something called as early gadolinium enhancement also, which we don't really use that much these days, other than in some acute conditions, but this is late gadolinium enhancement. And what you're trying to see over here is that the myocardium that is normal should be looking all black. So similar to the cine image is what you're seeing, the black is supposed to be the normal myocardium, and all the white stuff that you're seeing in it is the not good stuff. That's the gadolinium that is getting deposited. And what you're seeing is that you have large amount of this multifocal LG that is present in multiple patterns. So you can see there is subepicardial LG that is present in the inferior infroseptum. You have this subendocardial LG that is present in the same region in the inferior infroseptum.
That's not the best.
You obviously have a lot of involvement of the anterior wall also in the mid one slice over here. Yeah.
Yes.
Over here, you have a large amounts of involvement. I think that is RV involvement that is present in the very, very basal slices that is there, although the resolution is not the greatest that is being transmitted over here, but you have a lot of RV involvement. So the thing that is the take-home point, at least when you're looking at this LG, is that you have a large amount of LG in multiple patterns, which means subepicardial, subendocardial, mid-wall pattern, which is located in multiple locations. There was stuff in the septum, stuff in the lateral wall, anterior wall, inferior wall, and there was some stuff in the right ventricle as well. The other thing to keep in mind is that whenever you're interpreting LGE is that, is it in a coronary distribution or a non-coronary distribution and patchy? So this is a non-coronary artery distribution and a patchy distribution of LGE that you have.
So are any panelists ready to make a diagnosis, or do we need more testing? What's on your differential?
No, go ahead. So definitely, given the involvement of the anterior wall, septum, the multifocality of the lesion, sarcoidosis would be in my differential. Also, the myocarditis, although it doesn't have, we know that sometimes when you have parvovirus myocarditis tends to involve more selectively some segment of the lateral wall. Again, it's always in the differential diagnosis. Doesn't have anything that speaks of, for example, Fabry disease, particularly because of this involvement of the septum. Doesn't look like an hypertrophic cardiomyopathy, or could be, I guess, a burn down, but there's nothing to suggest hypertrophy. So I would say probably at this point, maybe with the sarcoidosis or myocarditis.
Excellent.
Can you explain what you see there? You know what that means, what this diagram?
So this is sort of what we were discussing before. I would just add one quick thing as far as the differential diagnosis is concerned, is that certain genetic dilated cardiomyopathies can have this looking dilated ventricle. Obviously, this one is a little bit different. There is a lot more LG that is present in different patterns. But if there were a few less spots of LG, then sometimes when you're reading this dilated cardiomyopathy is on the differential diagnosis. So over here, this is a basic sort of understanding of cardiac MRI late gadolinium enhancement pattern. So on the left side, you have the ischemic distribution, and on the right side, you have the non-ischemic distribution. The thing to keep in mind is that whenever you have ischemic late gadolinium enhancement, the late gadolinium enhancement, which is represented with white, starts from the endocardium, subendocardium, and goes outwards. So the figure A is the subendocardial infarction, which is associated with ischemia. And when that progresses, then it progresses into a transmural infarction pattern where the whole wall is involved. So when you see that multiple segments involved on a coronary artery distribution, then you're thinking about an ischemic pattern. And in the right side, obviously, you have the other side, which is a non-ischemic pattern in which you do not have the subendocardial pattern in one focus or in one coronary artery distribution, but you have the mid-wall and the subepicardial or the epicardial pattern, which is seen in C and D. And then the other thing that is not differential diagnosis is that you have certain systemic conditions like amyloidosis, sclerosis, where you have this diffuse subendocardial late gadolinium enhancement. In the non-ischemic patterns, depending upon the condition, as we discussed, as Dr. Trivedi mentioned, myocarditis in the mid-wall pattern, dilated cardiomyopathy, as we said, idiopathic, again, obviously important to know genetic variants. And then you have hypertrophic cardiomyopathy, sarcoidosis, as we discussed, myocarditis, Anderson-Fabry and Charcot's disease. They have slightly different patterns, which is beyond the purview of what we are talking about potentially today. The thing to keep in mind is that the wall thickness was normal, so the chances that this is something like a hypertrophic cardiomyopathy, which is mentioned over there, is relatively limited in this situation. The other thing is conditions of RV pressure and volume overload. So sometimes we see this RV insertion point LG multifocal. It's difficult. It is always on the differential diagnosis. In this case, that's not the issue because you have multiple other segments that are involved. But sometimes when you have those isolated segments involved, then it gets a little bit challenging as to what we consider pathological as far as underlying issues are concerned versus pure RV pressure volume overload issues.
Continuing, these are images, again, the parametric mapping values. So I won't do a disservice to all cardiac MRI readers out there to summarize this within a minute or a slide. But these are some additional features of MRI which are very helpful for the reader to provide information to the referring physician to make sense of what they see. And if there's any additional features or abnormalities in tissue characterization that can help move forward with the different types of differentials. So Dr. Agarwal, I didn't know if you wanted to speak more about this or if we should move on. Yeah.
Why not? So one of the things that's obviously there is tissue characterization. That is why we do cardiac MRI. And as you saw in the late gadolinium enhancement, we do visual assessment. But just moving beyond visual assessment, where we are using more quantitative or semi-quantitative parameters rather than visual assessment, you can come up with sequences have been developed where there are more quantitative numbers given, and we are able to quantify that based on what we are able to see. So your native T1 values, which is sort of a representation of your fibrosis or diffuse scarring, generally for most scanners, it is less than 1100. You have to obviously localize that to your scanner. So in this case, it was 1056. In cases of amyloidosis, where there is diffuse process going on, these numbers are going to be higher. In cases where there is fatty deposition, like let's say Anderson-Fabry disease or something, these numbers are going to be lower. But over here, the fact that the number is less than 1100, 1056 argues against the diffuse systemic process of infiltration where there is a large amount of extracellular space or volume expansion of fibrosis. Similarly, global ECV is something that we do pre and post contrast. Again, it is a marker of diffuse process. This is a bit on the higher side at 35%. In normal healthy individuals, you should be closer to the 25% mark. Up to 30% is what we allow for some errors to happen. At 35% is a bit higher, but you have to keep in mind a few things whenever you're interpreting these numbers. As you saw in the images, the walls were relatively thinned out, and then you can start getting a lot of volume averaging from the blood pool into the myocardium. And in that sort of a situation, you are going to have elevated values which probably can be potentially misleading. So whenever you're interpreting these global numbers, they have to be placed in the context of the morphology of the left ventricle, quality of the images, and put it together. And the value they add quite often in a day-to-day clinical bread and butter situation is when they add additive value to what you're seeing on LG images. Like certain cases of amyloidosis, where it becomes really difficult for us to understand, is this amyloidosis versus is it suboptimal nulling, patient mood, breathe, not enough contrast went in, or cases like hypertrophic cardiomyopathy. I think the value over here in this patient is the global native T2, which is your marker of myocardial edema. So whenever you're dealing with these cases which present acutely for any reason, One of the differential diagnoses, as we discussed, was myocarditis or acute inflammation. And then we can do this T2 sequence. Previously, it used to be done only with visual assessment, but now we have these mapping sequences where we are trying to understand if there are focal spots where there is increased edema as opposed to the rest of the myocardium. And there is a global value that we are able to get generally less than 60 milliseconds is supposed to be normal. Obviously, you have to localize it to the scanner again, but then you're looking at big spots to see if there are any major spots where especially you're seeing LG or wall motion abnormality, are you seeing elevated values? And if you see that, then you're thinking more about a underlying acute myocardial inflammation process. Over here, this is also normal. So when we put this all together with the cine images and the LG that we saw, we have a dilated left ventricle, regional wall motion abnormalities, multiple patterns of LG with relatively preserved T1 and T2 values against any significant acute myocardial edema. So most of the process looks more chronic rather than acute.
Again, one thing to always remember is that you need to normalize the scanner you're using, because, for example, we use a lot of 3-test lab MR for the PET-MR, and our values are very different also for the T2. So I would say this would have been considered abnormal. But in my experience, I find in agreement with what you were saying that there isn't necessarily a correlation also between what you see on T2 and what you see on PET. So I don't yet understand why we're seeing this discrepancy, but there's been cases where there was clearly inflammation detectable on PET, but not on T2. And I think it's probably inherent to either represents different stages of disease, like in terms of edema and infiltration of active cell, or rather different sensitivity of the two modalities.
For the sake of time, I'll keep moving. Okay. So let me deactivate. Activate. So this is just a free form to type in and answer. So what is your differential diagnosis at this point?
Are you trying to give us clues, Paul? Or is this what the audience is saying? I'm confused.
Yeah, it's just highlighting. There you go. Okay. Excellent.
There's one thing up there that I don't think has been mentioned yet,
Sure.
which is the arrhythmogenic with biventricular involvement. What does that look like? Is this consistent with that picture?
I would say that usually there's more involvement of the right ventricle, which we didn't see in this case. Also, I don't think it really fits a clinical presentation as well. Typically, what you look at infiltration, for example, of the right ventricle, which I don't think it was present, although I didn't see specifically images of that, but it wasn't apparent that there was a lot of RV involvement, although the RV was dysfunctional.
So I'm going to be a bit contrarian here, okay? I appreciate all of the cardiac expertise here, but I have to say, and I appreciate the differential diagnosis from a cardiac point of view. I think it's totally right on and legitimate. But I have to say, when I'm seeing this patient clinically, I'm looking at this much more broadly in the sense that if I'm considering sarcoidosis as a diagnosis at this point, and the CT of the chest, or the CT of the coronaries at least, doesn't show any adenopathy, and a previous evaluation is not suggestive of any extra cardiac involvement of sarcoidosis, my antenna go up, and I'm skeptical. Because now we're getting into an area that's highly debatable. Actually, I should say it's less debatable now than it was 10 or 15 years ago, but it's still debatable as to whether, there is this entity called isolated cardiac sarcoidosis. And I think most of us agree that it exists, but I also think most of us agree that it's not as common as at least some literature reports. And I think that when I see a patient with features of cardiac sarcoid without extra cardiac involvement, I definitely consider the diagnosis of isolated cardiac sarcoidosis, but I don't want to fall in love with my diagnosis of sarcoidosis. And what generally comes to mind is this a myocarditis? Is this a chronic viral myocarditis? Is this some other entity that can mimic cardiac sarcoidosis? And I have to be very, very careful about ruling these patients in as somebody who has cardiac sarcoid. Now, we haven't completed the workup yet. So there's a lot more to do here in terms of trying to characterize this patient as to whether they have cardiac sarcoid or not. But just broadly from a sarcoidologist point of view, this is someone who I would have a little bit of skepticism approaching and not purely from a cardiac point of view, jump to the diagnosis of cardiac sarcoid. That's the point I want to make.
What you have done differently?
I don't think I would have done anything differently. I think the approach would have been totally fine. I think that I just wouldn't embrace the, this is in terms of differential diagnosis, sarcoid number 1, sarcoid number 2, sarcoid number 3, right at this point.
So, and in line with what we were saying, there are studies that have shown that the diagnosis of isolated cardiac sarcoid is also based on the extent and the depth of your workup. And we never really do a complete and in-depth workup because even if we go ahead and do a PET in this case, we're not going to do a full body PET. So, which would be something that you would need to do to exclude completely the existence of sarcoidosis in other areas.
So what's the next step you would take to help you narrow this down?
Well,
I think, I mean, probably I would definitely go ahead and consider, doing a PET, either PET CT or PET MR to evaluate for evidence of inflammation. Another thing that, I think that would probably be the next step. And then based on the presence of inflammation or not, I would consider doing a biopsy if there is any evidence of active inflammation in here that I could biopsy. Maybe I would also send genetic testing as well, just to complete the workup.
Yeah, I agree with that. And I would definitely, in this case, send genetic testing. I think that there are a number of papers that have come out that have suggested that in patients who were diagnosed previously with isolated cardiac sarcoid, they've undergone genetic testing, and they subsequently had genetic cardiomyopathies or weren't appreciated prior to that diagnosis. And we also know that some of those genetic cardiomyopathies do cause FDG uptake on PET scan. So I'm not saying, let's just say you agree that, 15% of all patients with cardiac sarcoid have isolated cardiac sarcoid. I'm not saying all 15% of those patients have a genetic cardiomyopathy, but there is a percentage that do. And we've had patients who have both cardiac sarcoid and a genetic cardiomyopathy. Usually those variants are variants of undetermined significance. So we don't know exactly what this genetic cardiomyopathy means. And then in a few other cases, we found patients who actually have legit genetic cardiomyopathies, but they've had biopsies, extracardiac biopsies, that are consistent with sarcoidosis, which then gets us into a conundrum as to whether their cardiac involvement is truly due to cardiac sarcoid. And most of the time, we end up treating them as such because withholding treatment in someone who may have cardiac sarcoid is probably not a good idea based on their longitudinal history and the natural history of the disease. But it also, creates problems because you may be giving somebody a medication with considerable side effects that ultimately they don't need.
Yeah, and one of the cardiomyopathy that I've personally seen that present very similarly to sarcoidosis on PET is desmoplakin. Desmoplakin mutation really. So, and I've seen those because they were referred to me after having a diagnosis of desmoplakin mutation. And the question is that, do they have two diseases? Because we often also don't have pathology in those cases. So it becomes sometimes very challenging. And I think it speaks to the fact that we don't also have a diagnostic marker for sarcoidosis. So distinguishing comorbid condition from isolated diseases can be, actually most of the time.
As a reader and taking care of a few of these patients, there are three things I would like to add to what has been mentioned so far over here. One, whenever you're in this sort of a situation, go back and look at your review of systems and patients' prior medical history. Look at small things which you did not even pay attention to before. You were like, oh, this is just something. Skin involvement, eye involvement, that's not uncommon. Actually, when you look at the numbers, that's a relatively high number. So what you may have thought is nothing, actually it may mean something, and it may guide you towards the fact that there is more of a systemic process rather than isolated cardiac sarcoid. That's one. The second thing that is there is what we pay attention to when reading this imaging is that look at all the prior imaging that is available. Go back and look at all the lymph nodes that may or may not have been mentioned. Nobody ever paid attention to that. It was just forgotten. Nobody paid attention to it. So pay attention to that. The third thing is to back up what was said is the genetic history. There are two aspects of that. Make sure go back and talk to the patient, get about 2 or 3 generations, probably what is recommended is 3 generations of genetic history to figure out if there was any sort of a cardiomyopathy in the family that exists. There may have been some conditions which were missed or were not diagnosed to begin with. So, and the last thing is that especially in patients where you're going to have a tough time obtaining tissue based on how the patient course progresses, the value of sending off a genetic test is even more higher. So pay attention to all of these markers that are associated and surrounded. It is like a piece of a puzzle trying to put it together, because the significance of putting somebody on immunosuppression for the rest of their life is so significant that before jumping to the diagnosis, make sure you have crossed your T's and dotted your I's and not been a rush to start immunosuppression.
Thank you all. That was great. Okay. So luckily at Morningside, we've been blessed with a PET CT machine, and here we were able to obtain some beautiful images, attenuated, corrected. Dr. Agarwal, are you tired of talking, or would you like to take us through this?
This is the last bit I will talk.
Okay.
So for myocardial inflammation assessment, we get 2 sets of images in general. We get resting perfusion images, which is the top row, and then we get the FTG PET images, which is the bottom row. The resting perfusion images are just routine. They can be SPECT or PET. Ideally, wanted to be PET agent so that you can compare apples to apples, but the inflammation is assessed with FTG. This is the same FTG agent that is always used in oncology. But the difference that ends up happening is that for myocardial assessment, you have to do some preparation. And the preparation is a very key aspect of it. In preparation, what you're trying to do is you're trying to suppress normal myocardial glucose FTG uptake. What happens in regular situations is when there is glucose in the blood pool, then the myocardium will preferentially use that using your GLUT1 and GLUT3 receptors, and that is insulin dependent. But in cases when there is myocardial inflammation, there are macrocytes and lymphocytes that are present over there in that region to clear up the inflammation, and they are very, very glucose avid. So they are very, very FTG avid, which means that when we inject FTG, then the normal myocardium is taking up FTG based on your GLUT1 and 3 receptors, and your macrocytes and lymphocytes are taking up FTG based on your GLUT4 receptors. What you try to do in this situation is that suppress the normal myocardial FTG uptake that is present and bring out the inflammatory FTG that is present. The way we do that is get these patients to do a high fat, almost zero carbohydrate diet for at least 24 hours. These days for outpatients, we have gone up to 72 hours. And then we follow that up with overnight fasting. What this does is that decreases your normal myocardial FTG uptake and enhances your FTG uptake of the abnormal myocardial inflammation areas. There are 2 key points to keep in mind with this. And again, this is something that is present if and when you'll be ordering these tests and interpreting these tests. This interpretation is not in a vacuum. We have to make sure the patient does not have significant coronary artery disease. If there is significant coronary artery disease, unrevascularized disease, hibernating myocardium will look like this. So quite often we have physicians referring patients to us with like 3-vessel unrevascularized disease. They're like, do a PET scan. There is hibernating myocardium everywhere. And they're like, rule out sarcoidosis. We're like, we cannot rule that out. We don't have that technology, unfortunately. So that is a big caveat that is there. That is why it is important to get a good quality ischemia evaluation before cardiac cath, cardiac CT, cardiac PET scan. Unfortunately, stress echo and nucleus SPECT Regular bread and butter does not work for this because the stakes are very high. So make sure that is done. The second thing that is there is confirming the diet preparation to make sure adequate amount of ketosis is achieved. So we are very strict about this. Again, this is a trial and error process where we have become more strict with our interpretation in the context of what the preparation is. So we send out beta hydroxybutyrate levels in these patients. So some of you who will be dealing with these patients and sending them for PET scans, we'll always ask you guys, especially for the inpatients, please send a beta hydroxybutyrate on the morning of the test. The goal of that is to make sure adequate amount of ketosis is achieved. There is some literature that has come out in the past couple of years where if you are above 0.3, then there is hopefully adequate ketosis that is achieved. And when you read these FDG PET images, then the FDG is making sense so that you realize that the normal myocardial FDG has been suppressed. What we look for in this, ideally, if everything else is okay, is an area of a matched defect, where means on resting perfusion, there is a defect that is present, and in the same regions, you're seeing foci of active FDG uptake. When that is happening, you can say that there is active myocardial inflammation that is present. It does not mean it's sarcoidosis, and that goes back to the point that Dr. Trivedi was mentioning. It just says that there is inflammation. We don't know what the cause of inflammation is. You still need to put it together. And the other thing that can be present in these patients is that you can have what is called as burnt out sarcoidosis, where you will not have areas of FDG uptake, but there will just be areas of resting perfusion abnormalities. And that is just an advanced stage where probably we missed the boat of trying to treat that acute inflammation, or the acute inflammation was treated and now there is a scar that is left behind.
So just personally, I don't like the term burnt out sarcoidosis. The reason I don't like it is because we know from experience that perfusion defects, which are deemed to be scar, are definitely modifiable. They're modifiable with therapy. And there are people who have perfusion defects that persist forever. And there are people who have perfusion defects that change with immunosuppressive therapy. I think if you have a series of PETs over a certain period of time, I can't tell you what that period of time is, let's say a year, and the perfusion defects are the same, then they're no longer modifiable, and it is scar. And the extent to which it correlates with MRI, I have not been able to establish. But what I can say is there are people who are newly diagnosed who have FDG and perfusion defects. And when you treat them, you would expect that their perfusion defects don't get better. You would expect only their FDG to improve, and they both improve. And sometimes they actually go away. So what perfusion actually means in the context of the disease process is, I think, still a work in progress.
And actually, I wonder whether, how was the basis of this assessment done in terms of understanding that it was really a perfusion defect? Because the assumption is that the granulomas, the disruption of the tissue causes a perfusion defect. But I don't know whether that's been proven in a histological way. So it's really very unclear what causes this perfusion defect.
Yeah, that's true. Again, I think it's a work in progress, at least when we are interpreting these images to back up what has been said, in addition to the other caveats that I mentioned. One of the things that is there with the perfusion defect is, as far as the basic understanding is concerned, is we look at two things. One is this perfusion defect persistent, and is that in a region where there was previous FDG uptake? So if there was FDG uptake in a region and then there is after that left behind a perfusion defect, then that is most likely a scar. Having said that, when there is acute inflammation that is present based on the theoretical models or whatever is the current sort of expert understanding, is that you can have a lot of inflammation where there is myocardial edema and everything. So you have microvasculature that is being compressed. And because of that, there is a perfusion defect. As the inflammation gets better, hopefully the perfusion in that region, if it is not permanently scarred out, should get better. So quite often you will have these situations, as Dr. Morgenthau was mentioning, is that patients are labeled with burnt out sarcoidosis too quickly and too early without having gone through the serial scans. And you will see regions where some regions which had a resting perfusion defect before, they will get normalized after they have been treated adequately. But again, it's a work in progress. We still are understanding a lot about this.
Great. Can you bring this back to this patient and walk us through the scan?
So the previous one.
Yeah, sure. So this is what we were trained to see initially with the color map. So
want to go ahead, Paul?
Sure. Yep, so essentially, what we're saying is we're going from the kind of the resting perfusion images here to see if there's any obvious, or maybe not obvious, perfusion defects from base to mid down to the apex. So here, as the base comes into frame here, you can see that because of this color here, you want to see a very colorful full donut. But here you don't see that as you kind of come down into the mid part of the LV, and you see kind of this darker area here. So you could say, you know, you see some perfusion defects potentially in the infroseptal, septal, anterior, anterolateral walls of the mid, maybe even the base coming down, and see it here more significantly here in the inferior infroseptal walls. And as you get closer to the apex, you see another potential perfusion defect come into play in the anterolateral walls. Right. And then you also want to cross-reference with your horizontal axis views and your vertical axis views to get a better view of exactly where maybe you might be seeing those defects more here on the, as you start from the inferior to anterior. And as you move across, as you're going from inferior to anterior, maybe you say that you see some defect here in the basal inferior. And then as you get closer to anterior, you see this come into play on the anterolateral side mid wall, or mid lateral wall. And then here on the vertical axis, you see this on the inferior wall, going from septum to lateral wall, and the inferior here. Almost like bites out of here, so patchy. And then you try to look at the FDG uptake images, as Dr. Agrawal spoke about, to see if there's any sort of uptake that fits in, almost like fits in like a puzzle piece in those areas, to see if there's a pattern associated with certain diseases. So you do see it here, again, in this inferior apical, inferioseptal. Again, here, as I spoke about before, the anterolateral walls. And you kind of do that throughout. And then we also, use the black and white images to kind of help, hone in on some of these areas of FDG uptake, which sometimes a little bit more obvious here.
That's great. And so what was our overall conclusion from the PET scan?
So, and then these are the whole body. We always like to look at these as well to see exactly if there's anything else, especially if a patient has a device that could also cause some of this uptake or artifact. So overall, there's large size area multifocal FDG uptake associated with this match perfusion abnormalities in the basal, mid, inferior, infroseptal segments, basal anterior, basal to mid, anterolateral segments, and apical lateral and inferior segments. Essentially, so based on these areas of focal FDG uptake and extracardiac FDG uptake that's present, overall the findings are suggestive of active cardiac sarcoidosis, and this is labeled as probable, highly probable. And we can speak more about that here.
Let me just
Sure,
one quick
sure.
comment. We don't see much involvement of the right ventricle, so I don't know whether we have a good explanation up to now as to why the RV is dysfunctional.
Dr. Morgenthau, the PET report says highly likely sarcoid. I know you're appropriately cautious. Is this, are you convinced now, or is there more that you want to see?
So, I think there tends to be sometimes an over-reliance on technology. And, if you look at this historically, we were sort of buying into PET long before we knew what it means. And we know a lot more about what it means now, but there are still questions, as we've talked about. And the reason I bring this up is I think that, lots of practitioners who do this for a living, they do the PET scan and they say, oh, there's no FDG uptake, in the bones, or there's no FDG uptake in the spleen. So, there's just, all we have is a PET that's showing activity in the heart. That's the end of the game. We don't see anything systemically. And that may be true in some patients, but there are lots of other clues that you can look for clinically that help you determine whether somebody may have active disease. And what I mean by that is, there are plenty of patients who have sinonasal disease, for example, and they haven't gotten to the point where they have an infection. They haven't gotten to a point where they have, chronic impaction of the sinuses. So you're not going to see anything on PET scan. You may not even see anything on CT scan or MRI. but they're reporting chronic nasal congestion. And they get an exam by an ENT and they have, turbinate hypertrophy and so forth and so on. And, clinically, you can make a diagnosis of sinonasal sarcoidosis. The same is true of, for example, granulomatous interstitial nephritis. You may not have uptake on PET scan in the kidneys, but there are plenty of patients who have an elevated creatinine, and when you do further evaluation, you eventually do a biopsy and you find granulomas in their kidneys. So the PET scan is an important tool, it's an adjunctive tool, it's a very useful tool, and frankly, I think it's the most useful for cardiac sarcoid. But when it comes to extracardiac organ involvement, it is not a substitute for clinical suspicion, clinical evaluation, and sarcoid is a systemic disease that must be interpreted within a clinical context. So these findings on the PET scan always have to be interpreted with a clinical context, and as Dr. Agarwal said, they cannot be interpreted in a vacuum. That's number one. Number two is, whenever I talk to my patients about PET scans, I always tell them, think about the climate, not the weather. And a PET scan may be getting better, but it may not be normal. And if you freak out and you say it's not normal, I've got to boost my immunosuppression to X, Y, and Z to suppress this PET scan to the wazoo, oftentimes you're going to make a mistake. So I just think clinical context is a really important thing to consider here. In terms of what you asked me, the question, I think I'm still thinking isolated cardiac sarcoidosis or some sort of myocarditis. And I would continue to look for evidence of extracardiac sarcoidosis to support the diagnosis, but I wouldn't necessarily dismiss the diagnosis of isolated cardiac sarcoid just because I can't find any extracardiac involvement.
Can I add one thing, just to make things a little bit more complicated? It's also important to remember that what we do with the PET, we use FDG. So we assume that this FDG is going to be taken up by cells that are metabolically active, but it's not a specific tracer for any of the cells that are forming the granulomas. So we don't really know if different stages of sarcoidosis are really corresponding to different uptake of the tracer. And I can tell you that because in using other tracer that are more specific for inflammatory cell, like dotatate, for example, that labels macrophages, you can see sometimes a discrepancy between FDG and dotatate uptake. So it's also important to remember what kind of tool you're using to look at the disease. That's why the context is very important.
Yeah, sorry, I don't mean to interrupt. I just saw a patient who had a somatostatin positive tumor who came to see me because they had a positive dotatate scan and they wanted to know what was sarcoid and what was tumor. And I got to tell you, it was a heck of a case.
I know we're getting short on time, and I've got the last slide up here about what we do next. I just want to ask our panelists about management. So Dr. Morgenthau, in terms of using imaging, how do you factor that into your ongoing management of these patients in terms of titrating immunosuppression? And Dr. Triviere, you've had some recent papers on phenotypes of sarcoid risk stratification. How do you think about ICD placement in these patients?
So I would say, again, I think for the detection of active cardiac sarcoidosis, the monitoring of response to therapy, the PET scan is probably the best tool that we have, but it cannot be interpreted alone without clinical judgment. I think that the majority of the time I do not try and titrate my therapy to make a negative PET scan. What I like to see is that the PET scan is constantly going in the right direction, but I like to interpret that PET scan in a clinical context. And what I mean by that is, how is the patient feeling? Is the patient symptoms improving? Does the patient have an arrhythmia burden? Is the EF improving on an echo? And looking globally at the patient and saying, is the response on PET scan consistent with the patient's overall clinical condition? If the answer is yes, then I do have to make some judgments about the therapy and the dosing and duration and things of that nature. But generally, I'm reasonably happy with where I'm going. If for some reason a patient is on therapy and there's absolutely no change, or there's resurgence or recrudescence of inflammation or total lack of response, to inflammation, then I have to start to rethink my therapy. I can tell you from clinical practice, I've seen so many patients that have been treated with gazillion amounts of immunosuppressive therapy in order to get the PET scan negative. They've developed cryptococcal meningitis. They've developed, millions of different types of infection, and I just think that it's really a mistake. We probably don't have time to talk about specific therapies, but I think that that's another really important subject. I'll say one sentence on this. Take-home message. All medications besides prednisone are steroid sparing, okay? If you look at the literature, you're gonna find first line, second line, third line. Personally, I very much disagree with this analysis. These medications are not second line and third line and fourth line. Prednisone works in 95% of patients. When it doesn't work, it's the wrong diagnosis or the scar. And the medications that we use, in addition to prednisone, are to spare the amount of prednisone that we need to give patients. They're not instead of. So if prednisone doesn't work, let's go to methotrexate. That is not the treatment approach. The treatment approach is prednisone works. Now I have to get them on something so I can get the prednisone down and spare them the side effects of prednisone. One caveat being infliximab may work in certain situations, but prednisone doesn't, but that's a whole nother discussion that we don't have time for.
So yes, in terms of phenotyping, we have done quite a lot of work looking at MR positivity and PET positivity to determine whether or not this detailed phenotyping on PET MR could help us understand the prognosis of the patient. And in using very stringent criteria, looking essentially at the presence of both MR positivity and FDG positivity and coexistence of the two, as you can see in these images, we found that when we used that, we were able to predict the event. And in particular, what we also use, we use a higher percentage of scar burden, like a threshold of 5.7. So I think it's important to know whether or not you have scar and whether or not you have inflammation to predict the outcome in your patients. Another thing we did in the same cohort was to look at the location of scar and inflammation to see whether that would predict the risk of event. And what we did see is that the involvement of the anterior, both basal and mid, as well as involvement of the mid inferoseptum, and the mid inferoseptum, the basal and the mid inferoseptum was really predictive of adverse event in the form of ventricular tachycardia, ventricular fibrillation, or appropriate shock from the AICD. So I would say on the basis of our experience, and again, all sarcoid paper have limited case, but on the basis of our experience, I would say looking also at that particular patient, I would think that he would be at higher risk of events. So my next step would probably be to referring to electrophysiologists for implantation of an ICD.
Yeah, and one thing, Maria's work is really more specific than a paper that I'm going to just mention. And she's really pointed out some of the specifics. But if you want to just get a general idea, there's a paper that came out in 2017. It's a long name. I don't remember the name and I can't pronounce the name, but it was a joint paper by Society of Nuclear Medicine and Nuclear Cardiology. And basically they point out that LGE itself is a risk factor for ventricular arrhythmias. FDG is a risk factor itself for ventricular arrhythmias, and perfusion defects are risk factors for ventricular arrhythmias. So if you have 3 of these, then you are at much higher risk than you have none of these, and you are at much higher risk than you have 1 or 2 of these. So what those events are and how they correlate to specific areas and those things, that's what Maria has done. But this is an actually really good paper to let you know that you can risk stratify these people according to their advanced cardiac imaging.
Any value of biopsy of this patient?
Oh yeah, I mean, I think in a case where you think that there's isolated cardiac sarcoid, provided that the endomyocardial biopsy does not present too much procedural risk, I think it's very appropriate to do that. Lots of times what we try and do is if these patients have EP studies,
we try and do it at the same time. In this patient, I'm not sure, my personal opinion is probably they would go straight to an ICD rather than have an EP study, but I still think doing an endomyocardial biopsy in this patient is important if you can do it without a lot of morbidity. Because at least right now, without really digging into the patient, there doesn't appear to be another site to biopsy. The one comment I will make that's, I think, important for people to know is that, when you have normal pulmonary parenchyma, most people believe that the yield for diagnostic tissue biopsy with bronchoscopy is 0. And that's not true. So you can have normal pulmonary parenchyma and do a diagnostic bronchoscopy, and the yield is about 30%. When we have a classic CT scans with adenopathy and bilateral upper lobe symmetric perilymphatic nodules, the diagnostic yield is somewhere around 85%. So if you were in a bind and your patient said, hey, I am not going to be treated unless I know I have this disease, and you don't want to do endomyocardial biopsy, or you did an endomyocardial biopsy and you didn't get it because of the low sensitivity of biopsy, then you could potentially say, well, how about a diagnostic bronchoscopy with either endobronchial biopsy or transbronchial biopsy?
Terrific. I know we're getting short on time.
Sorry.
Paul, can you just close us out by
Sure.
telling us where the patient is today?
Sure. So back to the patient. So this is a recent patient. So actually scheduled for a bronchoscopy with biopsy yesterday. So we'll have some results. ICD was placed at the time when she was admitted, was started on GDMT. She did have improved symptoms on her last visit with her pulmonologist. The steroids were started just for the sake of time and with methotrexate, and genetic testing is pending. So just to let you know that there were extracardiac findings on the CTA-PE study after digging in a little bit with sub-centimeter lymphadenopathy. So thank you all to the panelists and the moderators and everyone else
Any questions from the?
who participated today. Thank you so much.
Thank you so much.